Good afternoon, everyone. My name is Paul Roscoe, and I'm the Director of Business Development at OntarioMD. It is my pleasure to welcome you today to today's Vendor Spotlight, the top 8 OHIP billing rejections for family physicians and how to fix them. Brought to you by OntarioMD and today's sponsor, Dr.Bill. We'd like to begin today's session with the land acknowledgement. We acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And now I'd like to introduce today's moderator, Chris Handscomb, Senior Medical Billing Consultant with Dr.Bill.
Thanks very much, Paul. Happy to be here today to represent Dr.Bill. We're a medical billing platform. We were founded in 2014 in Vancouver. And our mission is really to streamline medical billing, help physicians get paid efficiently, and free up time for patient care or work-life balance. Since our inception, we've expanded to service physicians in Ontario, British Columbia, and Alberta. Across the 2 platforms we own and operate, Dr.Bill and MD Billing, we have processed over $10 billion in gross billings with over 15,000 physicians and 125 group practices using our platform. We are committed to becoming the most connected medical billing solution in Canada. And in 2022, we acquired mdbilling.ca, combining over 25 years of experience to our team. My name is Chris Handscomb. I lead our enterprise sales at Dr.Bill, so working directly with hospital groups, clinics, and a wide variety of different physician groups to solve their medical billing needs. Joining me today is our guest presenter, Dr. Steph Zhou. Dr. Steph, thank you very much for joining us. She practices addiction medicine at Sunnybrook Hospital and family medicine at Don Mills Family Health Team, while also serving as an assistant professor at the University of Toronto Faculty of Medicine and on the board of directors for Toronto Public Health. Passionate about finance, she offers webinars and lectures on medical billing, personal finance, and shares her expertise on her social media channels at Breaking Bad Debt. Given your very busy schedule, we truly appreciate your time here today. As Paul mentioned, today's webinar is top 8 OHIP billing rejections for family physicians and how to fix them. The lecture is approximately 45 minutes, and we do have roughly 15 minutes allotted for Q&A at the end of the session. We're going to use the chat function for all questions, so please, as we go through, feel free to put questions into the chat. Also joining us today is Veronica Borda from Dr.Bill. Veronica is our senior billing team leader, overseeing our team of billing agents for Dr.Bill in Ontario. So again, as we work through the presentation, post your questions in the chat. Veronica will be monitoring that to answer questions, and then Dr. Steph and Veronica will also be answering questions live following the presentation. So without further ado, I'll pass it over to you, Dr. Steph.
Great. Thank you, Chris, for the introduction, and thank you for Veronica for moderating the chat. And I also wanted to acknowledge 2 residents that worked on this slide deck with me, Dr. Aynaf Simoni and Zara Uddin, who worked on this, the research and evaluation for this slide deck as part of their resident academic project. Moving to the next slide, I also would like to thank several of the following individuals who helped review the slides and gave some feedback on the content of the slides as well. So first, we're going to introduce a little bit about the data that we found around people's billing patterns and what are the most common billing codes errors. And then we're going to dive into the actual technical information of this talk about how to address those specific billing errors and how to fix them. So I wanted to pass the mic a little bit to Veronica just to sort of share her experience as well as a billing manager and how it feels from a billing manager's perspective to manage doctors' billings. So Veronica, I'll pass the mic to you.
Thank you. Probably the first thing that comes to mind is one of the things that we want to accomplish the most with my team and with helping our physicians is helping them to keep current and understand all of the ever-changing rules and nuances that OHIP inflicts onto billing codes, things that used to be at one point and should be so simple can be made quite complex. Probably one of the areas that we see most of the communication coming in from physicians, either new to billing or new to billing on their own, not having an administrative doing it anymore, is trying to understand the scripted refusal and rejection codes that OHIP sends back on claims. Some of them are very descriptive and very specific to what is wrong with the claim and give you a good idea of what needs to be done in order to correct and resubmit it. And then other ones don't make sense whatsoever. They don't really have anything to do with the issues on the claim. So we're here to support that. And that's probably the top reason that we hear from our essentials customers, which is basically the monthly plan where they are managing their own claims. When we get their request coming in to upgrade to our comprehensive plan where we're managing the claims for them, probably the most popular reason that we hear is because they simply can't make heads or tails of how to fix their claims with the explanations that OHIP is sending back to them. So we do.
Yeah, and I wanted. Sorry,
we
go
do
ahead,
spend a
Veronica.
lot of time just staying current on like bulletins and changes and trying to understand them ourselves first before giving our support.
Yeah, and I wanted to bring Veronica's perspective in parts of this presentation because for a lot of the people that we surveyed, billing does contribute quite a lot of hours of administrative time. And because of the frequent changes to the billing codes, especially with the Faux Plus model, people do lose income whenever the change happens and they're not kept up to date on the change as well. So that's why I just wanted to highlight the problem that we're trying to address here with this billing education.
For sure.
Okay,
And
so I'm going to
also
skip.
just to mention the added stress of the time frame to submit changing from 6 months to 3 months is just
That's
another
right.
added layer. So all of this time is spent entering the claims, and then within 24 hours, OHIP lets you know that half of them they wouldn't accept. So yeah, it's definitely a heavy task.
Yeah, and we'll definitely touch on that 3 months and 6 months change in one of the later billing slides as well. So before I begin, I just wanted to know who is in the audience today because the billing can be a little bit different across different practice groups. So a poll will come up on your screen or on I believe it's going to come up in the chat. And I just wanted to know what are people's practice types. So we're seeing the responses come in. And it looks like, let's see, 55 responses so far, waiting for the numbers to stop moving. It looks like the faux is the biggest, most common practice type people are joining from. And then fit and faux are the other types. All right, okay. And then some of them are RNPGA. Oh, I actually don't have that listed on the presentation as well. Okay, sounds good. Let me move on to the next slide. And then what is your practice level? Are you a resident? Are you in your early career, mid-career, late career, or other? Also, it's interesting. We're seeing a lot of other join the call. So I'm kind of curious, like, if you're other, what category are you? Are you in not in medicine? Are you a billing manager or admin, clinic manager? Oh, billing agent. Got it. Okay. I see. So I'm going to wait for the numbers to stop moving before we can see the results. Great. So it's great to see that a lot of admin are joining this call as well. Okay. And I think when you vote, you can see what other people voted for. And then how do you bill? Do you submit and reconcile your own billings and rejections? Do you use a third-party service to manage your billings and rejections? similar to like MD Billing, Dr.Bill, those are third-party services. Do you have a billing manager who takes a percent of the billings? That's how they're paid. You haven't looked into it yet, or other, specify in the chat. So I guess if you are a billing manager, you would be in the category of your clinic hires a billing manager, for example. So I'll wait for people to vote just to see what people are voting for. I see. So a lot of people, some people are saying staff, the staff physician submits, but you do the reconciliation, you do the reviewing. Okay, I'll wait for the numbers to sort of stop moving. Okay. All right. And then my next survey is how much time do you, if you're doing the billings, how much time do you spend dealing with billing rejections, including things like following up, reconciliation, resubmission, all of that stuff? And that will pop up in the poll as well. Or maybe you're not sure, right? So I'll let people click their answer in the poll. So far, it looks like the leading answer is 5 to 10 hours a month, which is a pretty significant amount of time. It's almost like more than a half day. Some people are also unsure as well. And this is important to know because if you're in the faux plus model, you can't bill for time spent billing, right? So it's your own time that you're spending looking at billing reconciliation and the rejections. Okay. Some people say I spend 7 to 15. And then how much revenue do you lose because of billing rejections per month? So that poll will pop up on the screen. And some people don't know, some people do know, but we'll see what people say. And this is where it's really insidious, right? Because if you don't actually know how much you're losing to your billings, you might actually be losing quite a lot, right? And so it is important to keep track of what did not get paid. And some billing softwares do this for you. They will keep track of how much billings have been rejected and the total dollar value of that. So I'll let folks respond to that. Yeah, a lot of people don't know, unsure. Okay, it looks like I'm seeing the numbers look like they've stopped moving. Like the most common answer I see here is $1,000 to $2,000 is what people are saying they're losing per month, which is not insignificant. Like that's basically like a preventative care bonus lost right there in a year. And so I just wanted to share with you some of the results the residents have collected from surveying 74 other physicians. And most of these physicians have been practicing less than 5 years or less than 10 years. So they're early to mid-career physicians. And most of them, similar to yourself, they do their own billing or they share the task with an administrator. So a lot of times they would submit the billing, but they would put the billing in, but the administrator would submit and reconcile. And this is what most people said were their most common billing rejections. EH2 by far the highest one. And so we're going to talk about how to fix some of these ones in this presentation today. And then how do you compare in terms of how much money you're losing to billings compared to other people? Most people are losing less than $1,000, but actually a very large amount of people just don't know how much they're losing in revenue. And this is where it's very dangerous for you, right? Because you don't actually know how much you're losing. And so a lot of times you might actually be making more. You could have been making more, but you just don't know how much more. And also a lot of people don't deal with the billing rejections themselves, but for those who do, it does take up almost more than a half day of administrative time per month, which is still pretty significant. And when we also try to speak with other billing managers on LinkedIn, they had similar perspectives as well. They also spend a lot of this time addressing people's billing rejections, and people lose up to $1,000 to $3,000 per month from rejections. So now let's talk a little bit about some of the basics around billing. Before I begin, I'm just going to see if this poll could pop up, because I know we were trying to figure it out earlier. How confident are people here already in terms of knowing what codes to bill? Are you strongly disagreeing to this statement that you're confident, or do you strongly agree? So I'll let people vote. And just wanted to know like how in-depth to go into. It seems like most people here are voting for the slightly agree, strongly agree. Most people do know the billing codes. Just so you know, just so you're aware, this talk is an hour, so we won't be spending a lot of time on discussing how to bill, just to save time. But there are talks I've done in the past that do discuss this. Okay, and then yeah, someone says strongly agree to knowing the codes, just not confident on managing the errors. Whoops. And then the second poll will pop up on the screen, which is how confident are you in managing billing errors? And this is where I find most people are not that confident. Yeah, slightly agree. Yeah, and this is the nice thing is we have a billing manager joining us to talk about it as well. And often in my presentations, I really like crowdsourcing. So sometimes, you know, there isn't exactly like a handbook on fixing billing rejections out there. It's not like there's like it's different than having the schedule of benefits. The schedule of benefits tells you what to bill, but there isn't something like a handbook like the schedule of benefits for rejections, right? And that's where it's challenging for a lot of people. And most people said slightly agree. They are somewhat confident, but also just almost as many slightly disagree as well. So this is just for the people who are very basic. I'll just skip through this slide because most of you are not at the basic level. But in order to start billing, the most important thing is you have to have a billing number first. And I've sort of listed out sort of the steps in getting the billing number. But also it's really important that you also have an MCEDT account and you go in this account because this is where you can look at what billings were paid, what billings were rejected, what are the errors that came out of this as well. However, there are also faster ways of seeing your billing rejections outside of MCEDT, and some people can see their billing rejections through their billing software, whether it might be like through their EMR system or maybe through a third-party billing software. The other important component I just wanted to briefly cover is just knowing what components you need in order to actually bill. So you need a billing code, but you also need a diagnostic code. And a lot of times people, when they type in the billing code and the diagnostic code, it's also important to pay attention to the submitted section. If your billings have not been submitted, then obviously you won't get paid. And that can actually increase the likelihood of you getting one of those errors down the line for stale dated billings, right? So I just wanted to highlight these three big components that you have to look into on your EMR system to make sure your billings are actually submitted to avoid certain billing error rejections. A lot of people will ask, okay, how do I even see my billing rejections in the first place? If you are using a third-party software, so this screenshot was from MD Billing, there is a rejected claims section that shows you. And when you click on it, you can sort of see based on the patient's name, the ID, and then what is the error code. And based on this, you can take actions to make the changes to fix it. On an EMR system, the screenshot for myself in my clinic, we use Accuro. And so we usually look at the remittances section. And then we sort of see here the explanatory codes, what was paid out versus not paid out, or what codes were sort of adjusted. So Sometimes the full amount is not paid out, maybe just an adjusted amount, maybe half the amount or a quarter of the amount actually gets paid out, especially if it's a multiple billing codes that you're submitting. And usually there are some explanations here as well. If you were to go directly to the source, like you're not going to look for your billing rejections on the EMR system, you can go directly into your MCEDT account and you can see error reports. And these error reports usually come into your account fairly quickly since the date you've submitted them. What they kind of look like is very confusing, which is why I usually recommend using the first two methods to look at your billing rejections rather than going directly into MCEDT. But basically highlighted in yellow were the billing codes, highlighted in pink was the date that it was billed, the blue was the diagnostic code, and then in yellow again was the error code. And then it doesn't actually tell you what this error code means, so you usually have to use like a lookup tool, which I'll talk about in the next slide, to identify why this particular code that I billed was rejected. So let's also talk about the two types of reports that you might see in your MCEDT. One of them is called the claims error report, which is usually when the claim is just full on rejected. It got paid at zero, and this appears pretty quickly. Then you also have a remittance advice report, which actually just tells you what you got paid, which billing codes were paid. But sometimes some of the billing codes, they don't get fully paid. They might get certain amounts paid, certain amounts not paid. They have an adjustment to them, right? And so that's where you could find the different types of codes. And how you know it's a different type of codes, which one is a remittance advice report versus error report, is usually remittance advice reports have 2 digits, claims error reports have 3 digits. And when you are addressing errors on the remittance advice report, so let's say something wasn't fully paid, or maybe it could have been paid, like it's not like a full-on rejection, you can always submit a remittance advice inquiry within 4 months of notice and 6 months of date of service. If it's something that just fully got rejected, or you are trying to submit a various combination of billing codes that may get rejected because, for example, let's say you do 2 home visits for a patient. One of them is to pronounce death. One of them is a follow-up. Usually you can't submit 2 billing codes for a patient on the same day, like 2 different billing codes for that patient on the same day. There's certain rules that allow to get rejected. But if you know that it might get rejected because it's an irregular combination of codes, or maybe it's like some sort of, it bypasses certain rules, like the billing limits for certain codes, like diabetes codes, they have a certain limit to them. There's a manual review you can submit before even submitting the code fully. So there are certain ways of correcting claims error reports. And so in this talk, we're going to try to talk about both the remittance advice error codes and also the claims error report error codes. I'm not going to spend too long on this slide, but it's just for comprehensiveness, just to show you that in a claims error report, usually there's the letters, and each letter sort of has a reason behind why they chose that letter. That kind of sort of explains what that code means. It's still confusing regardless, so I usually don't really pay too much attention to this. If you were to take away anything as a resource from this lecture, I would highlight these 2 particular links. The first is called opsmed.ca. They have a OHIP rejection code lookup. And what you can do is you can submit an error code, a remittance advice code on here, and it'll tell you what it means. Because usually if you get ADF, well, what does that mean? I have no idea. You put that in, it'll tell you what it means. And for some of them, it will actually tell you how to fix it. Dr.Bill also has an OHIP billing error code lookup as well. So these are 2 takeaway resources to have in your toolbox in deciphering what these 2 digits and 3-digit codes even mean. And so now in this part of the presentation, we're going to talk about what are the most common codes we see. So these are what the 74 people voted for as the most common codes and what the billing managers told us. We're going to start with the remittance advice reports, the D3 and I2s, and then we're going to move on to the claims error report codes. Okay, so when you see a D3 code, what does that usually mean? It usually means that you have combined 2 codes together that based on the schedule of benefits, should not have been combined together. So for example, like let's say you combined a K039, which is a smoking cessation counseling code, with like an A007, for example, or maybe with a K005. Usually that code is something that is standalone, for example. So other examples might be like, let's say you combine like an A005, A003, comprehensive assessment with maybe like a pap smear code, which based on the schedule of benefits is not something you can't be combined. How do you know which codes can or can't be combined? The schedule of benefits does tell you. I think I also did a lecture in the past that's recorded on YouTube touching on unusual combination of codes. So, that I do cover that in a separate slide. But the main thing if you're trying to think of combining two codes together, always just double check the schedule of benefits to see if it actually can be combined. And then how do you fix this? You can always just remove that code that you can't actually combine together and resubmit, or take off that second combined code altogether. So you could change the code and resubmit, or take it off so that it's just one single code rather than a combination code, for example. If you believe that the two codes are allowed to be combined and there was just some sort of error on the Ministry of Health's part, you can always submit a remittance advice inquiry. And usually this is where a lot of physicians sort of debate. It's like, well, do I really want to do all this work for just an A007, for example, right? And so sometimes when people do delegate this task to a billing manager, those might be a good thing to delegate as well. I2s, you'll see it quite often, especially if you're working in some sort of AFP or income stabilization. AFP is academic funding plan, income stabilization model, and there's usually some sort of shadow billing component. Usually if you see an I2, nothing to worry about. There's usually not much, you don't have to do anything for it. The most common code we see that is rejected is EH2. And what does that mean? It just means that the patient has their version code, it's out of date. And so they might have their health card expire. We see this a lot in elderly patients. And so the other code you might also see related to the OHIP number is VH9. So if the number itself, the digits, are not valid, maybe it's a newborn, so they don't really have an OHIP number yet, or they haven't registered their OHIP yet, you might get one of these two codes. And so how do you fix it? So often the slower way is you tell the patient to go to Service Ontario to update their card. And it's tough to do this if you're in a walk-in clinic or if you have a senior who has mobility issues. The faster way is to sign up for a 9-digit Service Ontario help desk number. You would email 24x7@ontario.ca, and then there's a number that you can call, and you give them that 9-digit number, you give them the patient's OHIP number, the date of service, the patient's date of birth, and often the staff picks up pretty quickly. They will tell you what the updated version code is. And so this is something that I have delegated to my billing manager. She has that 9-digit code. She'll call them and help me fix those EH2 invalid version codes instead of having to chase down the patient. Now, in certain cases like newborns, it might be harder to fix using this method. And so one task you can delegate to the billing manager is just making sure to follow up on the family of the newborn, make sure they've updated their health card number such that when they come back for their next visit, they can bring the updated health card number because now their OHIP is registered. So these are just important things that can be fixed without having to chase down the patient for the most part. Sometimes you also will get an AT3, and this is the second most common code, and we see this a lot when we started providing telemedicine. And in order to bill, so with telemedicine codes, there is usually like an A101, A102. Those are the lower paying $15 and $20 codes. And you would bill that if you don't have any pre-existing relationship with the patient. So that patient's not rostered to you, for example. Maybe you're working in a walk-in. But if the patient is rostered to you, maybe you forgot to roster them, or they're part of your full practice, but you forgot to roster them, in which case you might get this AT3 error if you try to bill like an A007 plus K300 for a virtual visit. So the important thing in that situation is make sure A, you have to roster the patient, and B, make sure the patient actually submits that enrollment form so that you can have the physical proof that they're rostered to you. You roster them with billing code Q200, or if you're part of GP focused practice, just make sure that every 24 months you have done a video visit with them in order to establish that ongoing patient relationship, allowing you to bill the higher paying telemedicine codes rather than the lower paying ones. So I mentioned this earlier, what happens if they're rostered? It's just make sure that you check there is that ongoing relationship. You think they're rostered, they might say rostered on your EMR system, but just make sure that you've built the Q200 so the system knows that they're rostered. And then unfortunately, if they weren't rostered and you didn't roster that patient, you would have to bill the limited virtual service code and bring that patient in so you can roster them. Now, this is a very common billing code we've seen, and this is why in the beginning of the lecture, I talked about checking the submitted section on your EMR system to make sure it changes from no to yes for submitted. I also have heard stories where people's admin have forgotten to just submit the billings altogether, and as a result, certain billings were not submitted and then they became stale dated. So if you're delegating this to an admin person, just also make sure that you double check as well at the end of close to the 18th or the time your billings are to be submitted, that all of the billings change from unsubmitted section to the submitted section of your EMR system. So you get a VJ7 if you maybe procrastinated, maybe there was a life circumstance and you ended up submitting the claim more than 3 months from the date that you saw the patient. And so sometimes you just put in the incorrect date, then just update the date and resubmit and correct it. But if the date is actually correct and you ended up, there was some life event or some reason that you didn't submit your billings within that 3-month deadline, it used to be 6 months, but now it's 3 months. You can always email the claims management at ontario.ca explaining the extenuating circumstances. And then obviously this is just a reminder to try to bill daily and submit daily as well. Address rejections in a timely manner. On this slide, I'll also bring in Veronica to speak about her experience fixing these VJ7 claims as well. So Veronica, are you on the call?
Yeah, I'm here. Thanks. So since the change to the submission timeframe of 6 months to 3 months, we've definitely seen a huge uptick in stale date claims and having to deal with them. Not only the submission deadline, probably a really frustrating aspect that we see of this too a lot is that if a claim is submitted on time and it's sent back with an error that has to be resubmitted, regardless of how long OHIP took to send that back, the 3-month doesn't start again to reflect the date that the claim came back needing a correction. So let's say a physician sends in a claim with about 3 weeks leeway until the 3-month date is approaching, and OHIP takes 2.5 weeks to send the claim back, leaving you only 2 days to correct and resubmit. They really don't give you any grace with that. So definitely having your claims submitted as close to the date that they were provided, billing in real time, in other words, is really more important now than it was ever before these changes. Once a claim comes back, VJ7, sending in a stale date claim file to have them reviewed and hopefully paid, there is absolutely no guarantee that they're going to be paid. We do have a lot of our physicians that, for whatever reason, are catching up on billing, or we've heard many times that they've gone from, having an administrator or administration staff submitting on their behalf, and it comes to their attention that 6 months worth of claims were never submitted. How do they recoup their being paid for those services? So for claims that have never been submitted before, have never returned with the VJ7, but are past the 3 months to be eligible for submission now, we don't submit those before the physician has spoken to OHIP, because very often what will happen is they'll speak to someone at OHIP, let them know the circumstances. One thing that we always tell them to highlight during that conversation is the financial impact that it would have on them if these claims were to not be paid because they weren't submitted on time. And then OHIP will get back to the physician either by phone call or by email, and they will give them the green light to submit these stale date claim files. That way, we know that doing all the work of creating a certain file type and all of that is actually going to produce a payment on the physician's side. Unfortunately, they do, there is a lot of legwork to be done with these. When it comes to the claims that have never been submitted before but are past the 3-month mark, even for us, we can't call OHIP and request this exemption on a physician's behalf. They do have to make the call directly, especially when it comes to the financial impact standpoint of not having the claims paid. OHIP does like to speak to the physicians directly. I will say that since the submission deadline was changed from 6 months to 3 months, they have been showing a little bit more leniency on paying these. Prior to that change, the reason as to why they weren't submitted on time would have to be what they would call extremely compelling to pay these claims, such as there was a flood in the office and your computers were fried and you couldn't submit claims or something like that. Usually anything that would point to just an administrative mistake or forgetting to do a submission or something like that, they wouldn't even think twice about it. They would just tell you, I'm sorry, we won't pay them. They are being a little bit more lenient with that now. But at the end of the day, VJ7s in either fashion, either coming back stale dated or not having been submitted at all, is definitely one of the top things to avoid when it comes to billing.
Yeah, and I know that people in the chat have often said like they submit a claim on time, but then it takes like 3 months to find out, and then by then it already is past the deadline. And so that can and then someone had also mentioned in the chat that they've noticed like specialist billing family medicine codes, right? And it's causing more outside use as well. And those are all things that can also affect physicians' billings too. Let me just move on to the next slide, and Veronica, I'll let you continue answering some of the questions in the chat as well. I just wanted to highlight, bring this to people's attention. There is an info bulletin out there. I think I've included the link, but if not, you can always Google this info bulletin where they provided the update about that 3 months submission timeframe. And they also have a section on there that talks about like what happens if you need to resubmit a rejected claim that is now stale dated. I also just wanted to show you what the forms look like for remittance advice inquiry and manual review. So if you do notice that there was something that was not fully paid out on your RA, but you feel like it should have been fully paid out, you can always submit a RA inquiry. Or if you're looking to submit a combination of codes that may not get that may get rejected because it's an unusual combination of codes or it's a complex combination of codes, you can always flag it for manual review before you submit as well. And then you would do that through eSubmit. The other billing error that people get is AM1, service limit exceeded. And this would be a common example, billing a 5th diabetes code within 1 year when the max is 4. And so often what you would do if you see this error is that you can always submit under a different code. So maybe that might be an A07, or maybe that might be a K013, depending on how long you spent with that patient on the diabetes visits. It's really important if you have the ability to on your EMR system. Some EMR systems will flag if you've submitted the 4th K013 when the limit is 3 of them, for example. So just make sure to, before you submit the billings, to kind of scroll up on your EMR system and see how many times you have submitted that particular code already. A36, and so this is kind of what one of the members in the chat have commented on as well. Sometimes specialists do bill family medicine codes. I have noticed that myself. And if especially the other case I've seen this happen is if a patient visits a walk-in clinic or a telemedicine clinic in the morning, and then in the afternoon they come see you for a second opinion. And this is where it can be a bit challenging because whoever bills it first gets paid first and bills and submit it first, right? And so if you saw them later or you procrastinated your billings and you didn't submit the same day, then it goes to whoever submitted first, unfortunately. If you do notice that this happens to you, you can always unfortunately, change it to a lower paying code, like to an A7, or you might have to change the code altogether so that it's not the exact same code as the code that was submitted by the other doctor as well. So the key thing to prevent this from happening, either you submit really quickly, make sure you submit quickly, or try to switch the code to a different code that still can kind of meet the criteria for that visit as well. So just to test your understanding and to also, bring the discussion, develop some more discussion, I'm going to now do some cases, okay? And so the first case that will show up in the chat is, what do you find is the most efficient way to prevent a D3, which is invalid combination rejection? And I'll give some people time to respond while let's take a look at some of the questions in the chat. Yeah, so someone mentioned in the chat, codes in the 00 section of the schedule is meant to be used by any physician. That is correct. So specialists do not have any separate counseling codes, subsequent visiting codes. So it's appropriate to bill these. My understanding is that specialist billing codes from the 00 section do not lead to negation for family physician. This only happens when another 00 OHIP specialty physician, family physician. Yeah, so that is right. So a specialist billing a code usually does not lead to a rejection unless it's a family medicine who has like maybe a +1, but not necessarily like a +1 where they have the OHIP designation, so the OMA designation. So they might, and I've seen this with like addictions, like they do addictions as their focus or their specialization, but they haven't gotten the formalized, the formalized certification for addictions, for example, from the OMA. So in that case, I've seen it negate other family physicians as well. So I'm seeing most people are saying B, and that is correct. So always, whenever you're doing a combination of codes, unless you're really familiar with submitting that combination, just always double check the scheduled benefits to see if that can actually be combined as well. And then what I wanted to highlight is try not to bill the services on separate days because that would be fraudulent, especially if you saw the patient on a certain date, but you didn't see them on the next day. So try to bill the codes the day that you saw them. What is the most common efficient way to address EH2, invalid version code, after the patient has already been seen? So I'll give some folks some time to answer this question. Let me just see in the chat. Yeah, so it looks like most people are answering it as B. So that's the correct answer. Yeah, and so yeah, B, contact the 24x7 Service Ontario help desk. Okay. Next slide. Let's say a claim is rejected with VH9, health number not registered. What is the most appropriate next step? And it'll pop up. Yeah, and someone mentioned, yes, you can use the 24x7. It has a limit. I think it is 5, not 3. Because last time I usually delegate this, but when I remember I called them, they limited now to 5. And that can be something that's why I started delegating this, because I don't always have time every single day to call, but I try to make sure that the gap in between me checking the rejections is quite small, so that way you you can fix those rejections early without it building up and then having to call multiple times in a row to fix the billing error. Okay, and so yes, so a lot of people are calling the 24/7 Service Ontario help desk, and yes, sometimes they do actually help with the VH9 errors. But in certain cases where like they just don't have an OHIP number, or they just don't have they just haven't renewed their health card in a very long time, sometimes the 24/7 people will actually tell you, oh, actually you have to be able to reach the patient and ask them to call, like, bring their updated health card. It is not 5 times a year. No, thank goodness. Each time you call in. Yeah, and someone had also mentioned it is 5. They have allowed me to use more than one PIN when I call for more than one doctor. That is correct. My admin has also done that as well. Okay. And then question number 4, a consultation claim is rejected with AT3. What is the most likely reason for this rejection? This will pop up on the screen. My chat keeps moving, so I can't actually see the result. Yes, so it looks like 97% of people got this correct. The doctor-patient relationship was not fulfilled, so just make sure that you either roster the patient, have them fill in the rostering form, and build a Q200 to finalize that rostering. And then the final case question, a claim is rejected with VJ7 as it was submitted more than 3 months after the assessment. What is the best course of action? So I'll give some folks a bit of time to respond. And it looks like most people had said D, which is submit the manual request for claims review, give an explanation, and that's right. And so just some final tips, really just make sure most billing rejections can be prevented by billing in a timely manner, same day or next day, and obviously within the 3 months of service. It's always important just every week or every 2 weeks, just double check that all your billings were submitted, especially before that 18th deadline, which can be sometimes a soft deadline, but around that time is when I usually just check in my EMR system, whether it's Accuro, PSS, or whatever you use, to see if the billing was submitted. Try to check your claims error twice a week to get those fixed without them building up too quickly. And then also, if you do need to submit a manual review, try to do it early while you still remember the case and you still have the patient information. Always, you want to make sure that you got paid for your WSIB, you got paid for your OHIP billings, and then start off by making sure all of your doctors, if you're an admin, all of your doctors have a 9-digit Service Ontario help desk number so that your admins can call and fix EH2 errors and VH9 errors for you. Final seminar survey, just wanted to know, like right now, how confident are you knowing in which codes to bill, and how confident are you in managing billing errors? I would say more so the eval question is confident in managing billing errors. Just wanted to make sure we are able to address most of the big billing errors that you will come across. And if there are any other ones, please let us know in the chat, and maybe we'll bring Veronica on as well to discuss some of the other most common billing errors that we see. Sorry, the chat moves up and down very fast, so. So I'm seeing a question that pop up. Do you generally submit your chart note with your manual review and RA inquiry? So Veronica, what do you usually find? Like, do a lot of your doctors that you submit for submit the chart note? Because sometimes I also submit the record as well.
So I think it really depends on why the claim needs a review in the first place. If it's something like, a combination of codes that otherwise wouldn't pay together, then definitely OHIP's going to be looking for some medical justification as to why all the services were medically necessary. A lot of times in order to do that, they want to see chart notes, or if it's easier visually for them to get through a letter from the physician on their letterhead as well, kind of explaining why all the codes should be paid. With both a manual review and an RAI, the more information you can provide, the more chance that it's going to get processed and paid the first time around. I submit a ton of manual reviews on a daily basis. A lot of times they're for multiple procedure codes, trauma claims, the E420 that requires the ISS breakdown to be submitted, things like that. A lot of times they're sent back as if a manual review was never done, and we'll call and verify, and they'll just say, the notes probably weren't read properly, please send it again. So sending them in, again, doesn't always guarantee that they'll be processed the first time around, but definitely the more information, the better.
And then I'm seeing another question come in. Do you usually receive a response on an RA inquiry, or do you just check the next RA to see that it was paid?
So claims being resolved through an RAI don't update the same way that a claim being resolved through a manual review does. So a lot of times it's just checking RAs every month to see if the claim was paid, and then we manually update the status on the claim in our system then to paid, just to be a little bit more accurately when the physicians are looking at their paid totals and things like that. But in that respect, updating of the claims work very differently when it comes to RAs and manual reviews. We've had some RAs that have taken up to 8 months to process by OHIP. So it does mean checking every month, but eventually you'll see them on an RA.
Great. And then I see here, I saw this quite often. Someone was asking M1 error with Q040. And I think, Chris, you had also mentioned something above regarding that error code. I just couldn't find, because the chat just moved,
I had
so I couldn't
provided him
find
with that answer
the
'cause I
answer to that
couldn't-
question.
I couldn't access the chat, but the Q040 is a per patient code, not per physician. So if it's been billed and you get it back as an M1, it was billed and paid to another physician instead. So at that point, there's not really much that you can do to try and recoup. Even if you were to provide a manual review with like proof that, no, this physician did provide it, they won't revoke a payment that they've allotted to another physician just based on that.
Yeah. And someone had asked, where can physicians and staff learn more about billing and correcting billing errors? I think the best for me, I actually learned the most by fixing rejections myself. But I would think like if your clinic, you don't fix billing rejection yourself, probably a billing manager, right? Like coming to talks like this, speaking with Veronica, who has a lot of experience with helping people fix billing rejections, that's often like the best way to really learn, because they see billing rejections for many physicians, whereas for myself, I just see for my own billing rejections and I fix my own billing rejections. Someone had also mentioned they're getting referring physician or midwife rejections, but the billing number is correct. How do you usually fix this? I guess it depends on what code you are billing that is getting rejected. Like, is it something like an A905 or like an A900, like a consultation code, is what I'm wondering.
It also depends on what the refusal code itself is. Sometimes we see one that points to the information for the referring physician is correct, but for some reason that we're not told in that explanation, they're not eligible to be a referring physician for that code. So in those instances, it's Sometimes the explanation of the refusal code is really pointing to what the issue is. Sometimes you have to read in between the lines. But when we do get those ones that are the physician's not eligible to be a referring physician, what we do first is we go to that referring physician's CPSO profile online, and sometimes, by surprise, there will be a reason listed as to why that physician is no longer eligible to be a referring physician. And then in that case, we'll just let the physician know that we do need to use an alternate, whether it's a nurse practitioner. The alternate is going to depend on the scenario in which the patient was referred or seen. So there's a few different venues that you can take to fix those. But usually if it's not a typo in the information, then what they've sent back is correct.
Got it. I also saw this earlier, but it just moved. Someone had asked about the A35 code. I actually have not heard of the A35 code myself. I've heard of, are they referring to 35?
35?
Yeah,
Yeah, because
because I'm looking up
35,
A35 on
yeah, no.
billing rejections, but I don't see an
Mm.
A35. Maybe
No,
it's
'cause,
35.
I think so, because there are a lot of refusal and rejection codes that do mimic each other just with an A in front of them. So, for example, there's ADF and then there's DF that are basically the same things, but they land on two different reports. With a 35, though, that's only going to be on the remittance advice monthly report for rejections, and that's basically indicating a duplicate. So that means that somewhere along the line, that exact same code to that physician has already been paid. It could have been submitted twice by mistake. We see those pretty often too, but it's usually pretty easy to find the paid one just for clarification.
Yeah, that's usually what happens to me when I submit the same thing twice and I forgot I had submitted already.
Exactly.
And now we have a few minutes just for a few more questions. I think someone asked, I keep getting a VH4 code. How do I fix this? I'm going to look this up on my rejection code search tool, which I think I sent to you. I have a slide, but I'm not sure if it was shared in the chat. It was an invalid version code. It's also another invalid version code.
Actually, it
as
has
well.
it has a bit more to do with the eligibility date for the card itself. So let's say a patient was waiting for their OHIP card to come in, like their first OHIP card, whether it be because they moved here or whatever the reason is, and a service is billed for them even the day before that OHIP has it in their system that the card is eligible as of this date, it will come back with the VJ4. Sometimes that can
VH4, yeah.
be sometimes that can be fixed with a manual review if the physician provides a letter asking OHIP to maybe backdate that start date by a day or whatever that gap may be. But we do see those a bit often too.
Yeah. Someone in the chat had mentioned that the VH4 is a newborn nursery hospital code for well baby exams at the hospital. That's why I've never heard of it, because I don't do like well baby or obstetrics at all. But yeah, thanks Dr. West who posted that chat comment. And then I think someone had a common question also I had asked about is any billing suggestions for specialist billing versus family physician or resident. Yeah, this is a hard question because I only do family medicine. I'm a family doctor, so I'm not sure if Dr. Bill runs specialist billing rejections. I think the billing rejections are the same regardless if you're a family doctor or a specialist. Billing codes might be a bit different, but what I would suggest if Dr. Bill doesn't do any specialist billing lectures is you can always check your section, your OMA section. I know like the OMA section of anesthesiology, the OMA section of pediatrics, they do their own specialist billing talks for their members. So if you're part of that section of the OMA, definitely reach out to them. The slides should be shared, and I think the recording should be shared as well. And then someone had also asked about DF codes and V20 and MR codes. What do those mean and how to fix them? I've personally never gotten V20, so I would have to look it up. It looks like it's unacceptable age for diagnostic code. I think this is usually what happens when you submit a code for adults to like a pediatrics. The code should be someone who is like over 65, and then you submit that for someone younger than that. I wonder if that's the reason for the unacceptable age.
Yeah, there are some combinations where there aren't that many diagnosis codes or otherwise that are very age specific. But if there happens to be a combination where there's a conflict between the diagnosis pointing to an age and the code also pointing to an age, then it'll come back with that refusal.
Yeah. I think when I searched it up, the example they gave was the 916 diagnostic code, which is usually like a pediatrics well
With
baby
the
exam type code.
807 over 2
Yeah,
years.
instead of using 917, for example.
Mhm.
So now we're right at 1. So thank you everyone for attending the talk today. And I'll finally pass it to Chris for any last words.
Thanks very much. That hour went quickly, and the chat was definitely very, very fiery. So thank you both. As a reminder for everyone, the recording will be shared with all the registered attendees and available on both the Dr.Bill site and the OMD Vendor Spotlights area of their website. An evaluation link was shared in the chat by Revan, so please take a moment to complete that. And finally, Dr. Steph and Veronica, on behalf of Dr. Bill and all of the attendees, we just want to say thank you for being here today, sharing all of this valuable information and guidance on how to reduce rejections, how to correct them, and get compensated fairly. And I hope everyone has a great day.
Thanks, everyone.
Thanks very
Bye.
much.